I'm Charlie Pollack. I'm an emergency physician, currently at the University of Pennsylvania, but in a week moving to Thomas Jefferson University, both in Philadelphia. It's apt that an emergency physician present the data from REVERSE-AD, which is a study of idarucizumab, a specific antibody directed against dabigatran, because this is a drug that we would anticipate using only in truly emergent circumstances. Our presentation yesterday was an interim analysis. We have an ongoing global study aimed at enrolling 300 patients, and the data that I'm sharing with you yesterday and today are on the first 90 patients enrolled in the study worldwide. We're looking at patients who are taking dabigatran, specifically dabigatran, and present with bleeding that is judged by the treating clinician at the bedside to be so significant or so severe or so life-threatening that reversal is warranted, full reversal of the anticoagulation. That's part of the enrollment. The other part is what we call the pre-procedural or pre-surgical patients. If you look at the paper, these are called Group A, the bleeders, and Group B, the procedural patients. These Group B patients are those who are taking dabigatran and who have an urgent or emergent need for some sort of surgery or other operative intervention that can't wait at least 8 hours, and for which hemostasis, good normal clotting during the procedure, is warranted. So these patients were identified locally at the site by clinical means. There were no laboratory prerequisites for enrollment of the study. And all of these patients received 5 grams of idarucizumab. Idarucizumab is a humanized mouse antibody that was developed against dabigatran. It doesn't seem to react to or bind to anything but dabigatran. And in preclinical studies, in healthy human volunteers, in older volunteers, and also in volunteers with diminished renal function, as well as in animal studies, which tended to be more injury studies, the effect of idarucizumab was rather profound in reversing the effect of dabigatran anticoagulation. So our hope was to translate that into the clinical environment in this study called REVERSE-AD. REVERSE-AD stands for the reversal with idarucizumab of active dabigatran. That's the AD. So we are pursuing this study at what will ultimately be 400 sites around the world. The fact that we are enrolling 400 sites to try to find 300 patients gives you an indication that this is not a common occurrence. But it's clear that provider concern around the world about not having a specific reversal strategy for patients having these emergencies while taking dabigatran is significant. And there's been a lot of clamor for some sort of specific reversal approach. I should note that the more general approaches, such as withholding the drug, decontaminating the patient if they've taken their last medication recently, we can give activated charcoal and keep them from absorbing that, giving the patient fluid infusions to raise the blood pressure, giving the patient blood transfusions. These may sound fairly dramatic, but they're routine for patients who are having these sorts of complications. And most of the time, on the bleeding side, that can take care of these patients. On the surgical side, most of the time, by simply waiting a few hours, dabigatran has a short half-life, we obviate the need for reversal. But there is this small cohort of patients, for example, with intracranial bleeding, patients with exsanguinating GI bleeds, patients with true surgical emergencies like a peritonitis or multiple trauma that needs stabilization in the operating room, where we'd really like to have something very specific to reverse the effects of the anticoagulant. So again, that's all by way of background. Idarucizumab we thought might be that agent. And what we found in these first 90 patients is that reversal of dabigatran as measured by 2 well-validated tests, the dilute thrombin time, you'll see that abbreviated in the paper as DTT, or the ecarin clotting time, you'll see that abbreviated as ECT. By both of those measures, the effects of dabigatran were completely reversed in these live patients, not healthy human volunteers, but patients actually with these medical or surgical emergencies. The confidence intervals around our result were very tight, so the outcome was measured at any time up to 4 hours after the idarucizumab was given. The reversal was 100% successful, and the confidence intervals were 100 and 100, so there's really no leeway there. Idarucizumab was strikingly successful in reversing the anticoagulant effects of dabigatran. That effect was maintained out to 24 hours. That's an important distinction that we make with other reversal agents under study, that this is a more durable effect. And from a safety standpoint, we saw no problems with the drug. Now, we did see problems with the patients because, as I've described them, these are very sick patients. They're badly injured or quite sick patients. And this drug reverses anticoagulation. It doesn't necessarily immediately stop bleeding or save lives. So we did have 18 of those first 90 patients die during the 90-day observation period. 9 of these were the procedural patients. 9 of these were the bleeding patients. Half of the 18 died in the first 48 hours, and the deaths were uniformly attributable to what they came in with. But in all cases, the anticoagulation was reversed. And the other half died during the 90-day follow-up period. So it's important to position this drug appropriately. Again, I'm an emergency physician. When a patient comes into my emergency department with one of these emergencies, massive bleeding or a head bleed or significant trauma, and I know the patient's taking an anticoagulant, any anticoagulant, the list of my clinical priorities is almost always headed by the anticoagulation. What am I going to do about the anticoagulation? Because that's not making things any better. Somebody who's bleeding who's anticoagulated is going to bleed more briskly. Somebody who's anticoagulated has to go to surgery is going to bleed in the operating room. So what idarucizumab does, at least in these first 90 patients, is to remove that concern from my list of priorities. I can take anticoagulation off the table by reversing the effects of dabigatran and then address the lesion, the holes and vessels that may have been caused by trauma, or the need to go to surgery right away. So safe, effective, durable reversal of anticoagulation. Again, I must caution you, only with dabigatran. This is an antibody to dabigatran. It wouldn't be expected to have any impact against warfarin, against injectable anticoagulants, or against the anti-10A anticoagulants. So we are continuing the study. Again, our target enrollment ultimately is 300. And we're very pleased that the New England Journal chose to publish our article. They don't do that very often with interim results. So I think that, again, reinforces the fact that there's a lot of interest in this area of reversal of oral anticoagulation. Thank you.